Welcome. I'm Janet Johnston. I'm the asthma nurse practitioner in the pulmonary division here at Children's Hospital, and I'm also a certified asthma educator. This video will be a recording of what is taught at our inpatient asthma education class that's provided at Children's Hospital daily for families and patients with asthma. So it will move through a PowerPoint and have some videos. It's about 45 minutes to an hour long. So asthma, what every parent wants to know. If you've been on our website, you'll see that there's also printed resources, and the companion to this video is the Children's of Alabama Guide to Asthma. It's there in English and Spanish, and I'll refer to that at times throughout the PowerPoint. We have this class because either your child has been diagnosed with asthma or the doctor's concerned that your child is developing asthma. And a lot of really controlling asthma, the main key to that is understanding asthma and how the treatments work together. So why do we provide this asthma education class? There's some important tools that all families need to have for managing asthma. We want you to realize that you're in partnership with your child's doctor to manage their asthma. And we want you to feel ready and equipped to meet your child's asthma needs. For children that have well-controlled asthma, they should be able to do everything that other children their age can do. Today's topics, we're going to talk about how asthma affects the lungs, asthma medicines, asthma action plans and handling asthma flare-ups, asthma triggers, and asthma at school. So how does asthma affect the lungs? The primary problem with asthma is it's an inflammatory disease of the airways or air tubes in the lungs. And this inflammation causes swelling. Swelling in the airways narrows the space for air to move out of the lungs. It's not the same as an infection in the lungs, but an infection in the upper airway will often trigger and make inflammation in the lower airway worse. Your air tubes, if you look at the little picture of the lungs, the air tubes are larger toward the center of the chest. Every time they divide, the size of the tube decreases in half, and they divide multiple times as the tubes go deep into the ends of the lungs, the edges of the lungs. The smaller the tube, and if you can imagine, the smaller a child's chest, the more a little bit of swelling has more impact. So often it's the small airways that inflammation really gives difficulty with young children in particular, and even as children age. Asthma is a chronic disease. That's really the bad news of asthma that's often difficult to accept. Asthma can change over time, but it's a long-term problem or long-term condition that gives you intermittent symptoms. The goal is that you manage it over time, but there's not a cure for asthma. How severe the child's asthma is may change over time. You can develop asthma at any age of life. So what happens in the airway when a child is having an asthma? We're calling it a flare-up for this education. Some families call it an asthma attack, or when their breathing's bad, when their asthma's bad. If you look at the picture of the normal bronchiole, the normal air tube, if you look at the middle of the inside of that tube, you see that the space is open and there's ample room for air to travel in and out of the tube. When a child breathes, it should be quiet. There shouldn't be an effort to breathing, and there shouldn't be a noise or a sound with breathing. It should be painless. When there's an asthma flare-up, you'll see the lining of the tube is swollen, and that swelling goes to the inside of the tube, narrowing the space for the air to travel. There's also muscle bands that wrap around all of the air tubes, and they tighten, and the mucus that's produced naturally in the air tubes start to increase, and that mucus goes to the inside of the tube where the air travels, and that also takes up space. So all three of these things together, the muscles tightening in the air tubes, the swelling increasing in the tube, and mucus increasing and building up, all causes obstruction in the air tubes, making it more difficult for the child to get air out. This obstruction causes these common symptoms. Cough. It's the primary or the most common symptom of asthma. Often if a child is going to cough with asthma, it's cough that interrupts sleep in the night or when they first wake up in those first few minutes of the morning. Or the cough is provoked when the child becomes more active, running and playing. You may notice shortness of breath in the child. The child may complain of chest tightness, chest pain. Some children don't know how to localize that feeling very well, and they'll say their stomach hurts or their back hurts, just something doesn't feel right. Asthma symptoms, though, are in the chest. They're not in the upper airway. There's also a wheezing sound, which is the little whistly sound that you hear initially as the child is breathing out. Right at the end of breathing out, as the obstruction increases, that wheeze continues throughout the phase of breathing out. If the obstruction is really increasing, you'll notice the wheeze while the child breathes in and out. The softer it is, you may only be able to hear it with a stethoscope. It can become loud enough and severe enough that you hear it audibly without a stethoscope. So these symptoms can all be from mild or intermittent to more severe and more persistent, where they're there and they're not, they're really making the child's breathing uncomfortable. Providers think of asthma in two categories, either as intermittent asthma or persistent asthma. Intermittent asthma, those symptoms I just talked about rarely occur. They also just only occasionally have that airway swelling and narrowing from inflammation and tightening. Persistent asthma, the airway swelling and narrowing is there every day, even though some days they may not have symptoms, but their symptoms are more frequent than intermittent symptoms, and their flare-ups occur more frequently. In general, the goal is the child doesn't have symptoms more than just very infrequently, and flare-ups are very infrequent. Really, the goal is no flare-ups or not more than one a year. Your child's doctor can diagnose what type of asthma your child has. The goal of asthma treatment is that there's less airway swelling and narrowing, so fewer symptoms, better control, the child's leading a normal life, not restricted at all because of their asthma. Here's a learning question we have. The airway of people with asthma are often dry, swollen, or cold. This makes it difficult to breathe. I hope you answered swollen. Asthma medicines. Now let's turn our attention to that. If you're following along in the book, on page 8, There's a picture of the most commonly used asthma medicines. There are two types or broad categories of asthma medicine. The first one is quick relief medicine, and that's to be used by every child that has asthma or have available. Also, if a child has persistent asthma, in addition to their quick relief medicine, they also need a controller medicine. Now let's think about just the quick relief medicines. They come in different names, different colors, different way they're delivered, but they're all similar in many ways. Names such as Ventolin, ProAir, Proventil, Albuterol, Xopenex. Those are the most common quick relief medicines. You'll hear sometimes families refer to these as emergency medicine, my rescue inhaler. They work quickly to relax the tight muscles in the airway to make breathing easier. Once you take a dose, they only work for about 4 hours. So once you take a dose, within about 15 minutes, you should notice or the child should feel some improvement in their breathing, but then the medicine is starting to wear off within 4 hours. There's nothing in the quick relief medicine that prevents the symptom from coming back. And there's nothing in quick relief that treats or prevents airway swelling. Their job is to relax the tight muscles in the air tubes. So you open the muscles temporarily, but if the muscles want to squeeze, as the medicine wears off, the squeezing occurs again and the symptoms increase. Some tips about quick relief. We want every child with asthma to have quick access to their quick relief medicine, 24 hours a day. We don't call it rescue medicine because it's used when symptoms occur. It doesn't have to be, we don't call it emergency medicine because the child doesn't have to be in a breathing emergency before you give it. Just, it's what you use when you're having asthma symptoms. You add it to give you symptom relief. Symptoms get better with flare-ups, but they may return as the medicine wears off. A rule of thumb is you can use your quick relief medicine as often at home as every 4 hours, but if they're not getting better within 48 hours or 2 days, it's time to be in touch with your child's asthma provider. If a dose of medicine doesn't keep your child's breathing comfortable for 4 hours, that's also the red flag to let you know it's time to be in touch with your child's doctor about their asthma. It's starting to worsen. So, adding quick relief when symptoms occur, noticing how long you've needed quick relief. If it goes on for more than 2 days of regular use, you should be in touch with your doctor. Otherwise, make note of the frequency of how often your child needs quick relief, and that's information to provide your doctor when you go for asthma checkups. Now let's turn the attention, I'm sorry, I'm going to backtrack a minute. For quick relief medicine, that's also the medicine that should go with the child to school, to daycare, to when they go to spend the night with a friend or on a camping day trip. The quick relief needs to be wherever they are. Now let's turn our attention to the controller medicine. It works in a completely different way from the quick relief. It's used every day to control airway swelling and narrowing. It reduces the frequency and severity of an asthma flare-up. It comes in lots of different forms as inhalers, in dry powdered inhalers or nebulizers, lots of different colors, lots of different strengths of medicines. So it's not as interchangeable from one product to the next as the quick relief medicine is. Your doctor has intentionally prescribed a certain strength of controller, and that should be used until the doctor changes the prescription. The controller medicines contain an inhaled corticosteroid or steroid. Most families are familiar when their child has an asthma flare-up that the provider gives the child a dose of steroids by mouth, like Orapred or prednisone, prednisolone. Those are strong steroids that are the fastest way to get the swelling back under control. But those carry more side effect risk than taking the controller medicine, which is a microdose of steroids used regularly every day to keep the swelling in check. It's such a small dose that it's not enough to start it once symptoms and swelling is already underway. It's a dose to prevent symptoms from occurring. It's your everyday maintenance or preventive medicine for asthma. And if you have persistent asthma, you should have a controller medicine. Some tips about controllers. They're taken every day, even when the child is symptom-free, or if the child is sick, you still continue it. So it's used every day. I often tell families it's like birth control pills. You take it on a regular basis to try to prevent your asthma from giving you a flare-up. Controller medicines don't stop a flare-up once it's started. That's why as your child's symptoms increase, if you're not able to control it at home, you need to be in touch with your provider. Because it is a steroid, what's left in the mouth, you want the child to rinse and spit so that it avoids thrush or side effects of swallowing the medicine and we want to minimize possible side effects, maximize the benefit of the medicine. So rinse and spit. If your child uses a face mask spacer to deliver their medicine, you also wipe the face off where the mask sits. To be honest, this is often the most difficult part of really managing asthma for all families, is commitment to and accomplishment of consistent controller use. The families that are the most successful at doing this have made it a part of their routine. They have a plan for when they're going to use the controller medicine. Most of them are dosed twice a day. Most children will take a dose in the morning before they're out the door for school or activities, and then sometime in the evening. And having a plan, either to take it as you're getting dressed in the morning. Often families do it a child does it right before they brush their teeth in the morning, because that's a natural time you rinse and spit. Or they do it, and then they'll do it again at bedtime, right before they brush their teeth at bedtime. If that doesn't work for your family, think about what would work. If it's better to take it at supper time and take it in the morning at breakfast time, just plan a time that your child is going to get their medicine and then build the habit of doing it. Sometimes it takes things like setting reminders in your phone alarm, or putting notes on the refrigerator, notes on your bathroom mirror, laying the inhaler where you see it with your clothes when you're getting dressed, or your bedclothes when you're getting ready for bed. Different families have used different tips, but think about and talk with your family about what would work best for your family's lifestyle and schedule. The typical controllers are dosed where the inhaler will need to be refilled every 30 days from the pharmacy. Your providers, when they give you the prescription, there'll be refills that you just have to ask from the pharmacy so that you continue to use that controller medicine on a regular basis until the doctor changes it or decides to stop it. If your child's not already taking a controller medicine and you don't feel like your child's under good control, it's a conversation to have with your child's doctor. Sometimes if your child's in the hospital, the doctors will start a controller medicine at discharge and let your primary care doctor decide whether to control it. Some children have more severe asthma and they have more difficulty being under control, and your child's regular doctor may refer you to a specialist, to an asthma specialist, to be seen to try to help manage their asthma and get it under control. But sometimes that involves seeing a specialist. It can be a pulmonary specialist or an asthma specialist, an allergy specialist. Most asthma medicines come as inhalers, and they're often the press and spray inhalers, or what's called a meter dose inhaler, or an MDI. And whenever MDIs are administered, we always support using that with a spacer or a valved holding chamber. They come by different names, but for the purpose of this presentation, I'm calling it a spacer. Different companies make them. They may look differently, but they all work in basically the same way. And they're tubes that either have a mouthpiece on the tube or a face mask for a younger child. And then it's a tube. The inhaler goes in the back of that tube, and it's a way to guide the medicine that's sprayed from the inhaler to get past the mouth and throat and down deep into the lungs. This picture will show you an inhaler without a spacer, and the medicine is x-rayed where it shows up red, and you'll see that most of the medicine, even when you use the meter dose inhaler correctly, from how the drug company tells you to use it, most of the medicine lands in your mouth and you swallow it, goes to your stomach, and a little bit gets in the lungs. If you add the spacer, a little bit of medicine is deposited in the mouth and swallowed, but the majority of the medicine goes to the lungs, where you see the dark red in the lungs. And that's our goal. Asthma's in the lungs, so we want the medicine to get to where the problem is. You can have the right inhaler in your hand, but if your technique traps the medicine in your mouth and never gets to your lungs, no matter what's in your hand that would help your child, it doesn't work. If you're going to the trouble to take your medicine, we want it to get to the lungs. So let's show how do you use a spacer with a face mask with a young child. Then, how do you use a spacer with a mask with a preschooler? These are effort less on the child's part. They don't have to be able to hold their breath. A spacer with a mouthpiece is used with a child that's able to breath hold, and usually around the age of 8. If a child has special needs where he can't hold their breath, they can use a spacer with a large face mask, even into adulthood. So there's an option for any child of some form of spacer that will work for them. These videos will show you.
Giving an inhaler to an infant can be challenging, but it is possible. Until your child gets used to it, they may cry and try to fight the mask. Practicing with dolls or teddy bears can be helpful for your child. If your child is crying uncontrollably, you may want to wait until they are calmer. First, we need to remove the cap from the inhaler. Shake the inhaler and insert the inhaler into the spacer. Hold your child on your lap and apply the mask over her mouth and nose from behind. Use your hands to seal the mask to your child's face, as the child may be crying, twisting, or turning. Press the inhaler down once. Watch your child take in at least 6 breaths. If you hear a whistle, she's breathing in too fast. Remove the mask from her face. Replace the caps and have your child have a drink and wash their face. If another puff is required, wait at least 30 to 60 seconds and repeat all these steps. Remove the cap from the inhaler. Shake the inhaler. Insert the inhaler into the spacer. Place the mask over your child's mouth and nose, ensuring there is a good seal. Press the inhaler down once. Watch your child take in at least 6 normal breaths. If you hear a whistle, your child is breathing in too fast. Remove the mask from your child's face. If another puff is required, wait at least 30 to 60 seconds and repeat all these steps. Replace the cap and then have her rinse her mouth with water. Remove the caps from both the inhaler and the spacer. Shake the inhaler. Insert the inhaler into the spacer. Breathe out. Seal your lips around the spacer mouthpiece. Press the inhaler down once and breathe in slowly and deeply. If you hear a whistle, you're breathing in too fast. Remove the spacer and hold your breath for 5 to 10 seconds. Breathe out. If another puff is required, wait at least 30 to 60 seconds and repeat all these steps. Replace the caps and then rinse your mouth with water. Please note, if you are unable to hold your breath, take 6 normal breaths instead.
Now let's think about how to care for the spacer and inhaler. For all spacers and inhalers, they come with specific instructions for priming and cleaning. It'll be written in the product insert. You can ask your pharmacist. In general, they all have to be primed, the press and spray inhalers, before they're used the first time. And then if they've sat unused for several weeks, like your quick relief medicine, you need to prime it again. They also have cleaning instructions. In particular, the spacers typically are washed every week. So follow the instructions in your product guide. If you'll notice when you saw the videos, you seal the spacer to the child's face, and you only spray one spray of the inhaler into the spacer at a time. Even though a dose of the medicine may be 2 puffs or 4 puffs, you do 1 spray of medicine with 6 breaths or 1 breath hold for 10 seconds. Or you don't do all 4 sprays or all 2 sprays at one time with a single breath. The key is a slow, deep breath. With young children, you just seal it and let them breathe. With a child that can more control their breathing, you want it to be a slow, deep breath in. If you hear the whistle sound on the air chamber brand of spacer, it's an alert that the child is breathing in too rapidly. You can use the same spacer with different inhalers. You do want a child to always have their spacer and their inhaler together or with them when they need their inhaler. So if they're at school, they need a spacer for school with their inhaler as well as a spacer for home with their inhalers. But you can change out inhalers with the same spacer. They're durable, so until the spacer's cracked or torn, not fitting the child's face, you can continue to wash it and reuse it, often for a year or more. Commercial insurance, they're covered under durable medical equipment, not under pharmacy benefits. And if you haven't paid your deductible for durable medical equipment, things like wheelchairs, your spacer, you may often be paying full price. And they can vary in price from around $30 to $40 for a mouthpiece to around $65 to $85 for a face mask. At Children's Hospital, the Peds RX pharmacy, that's the outpatient pharmacy in the lobby, they sell a spacer product that's at cost to just try to make it more affordable for families that have commercial insurance. So if cost is a factor for you and you're in the Birmingham area, that's a good resource for you. To come to with a prescription, you need a prescription to get a spacer. If you have Alabama Medicaid, they will provide 1 spacer a month, up to 2 in a 12-month period. Nebulizers are another way that medicines are given for asthma. It's usually their quick relief. There's one controller product that can be done by a nebulizer. If you're using a nebulizer, remember to always use a mouthpiece or a mask so that the medicine is directed into the lungs, not just blown in the child's face. If there's problems with the maintenance or cleaning, the equipment company that provided the nebulizer are the best ones to be in contact with about cleaning the product, how to change the filters, getting replacement kits. If you only have a nebulizer for your child, it's something to ask your child's asthma provider about also having an inhaler with a spacer so that your child's medicines are more portable. Okay, our next learning question. Blank medicines relax tight airway muscles to help your child breathe easier during an asthma flare-up. Is that quick relief, cold and cough, or heartburn? I hope you said quick relief. So the quick relief products, they do just that. They give the child a temporary quick relief of symptoms, but they don't treat the airway inflammation or swelling. The controller inhalers or inhale steroids that treat the airway inflammation to try to reduce the frequency and severity of symptoms. When you take a dose of a controller, it doesn't give you symptom relief right away. It's the consistent use over time, where quick relief does, but it doesn't really treat the heart of the problem long term. Now let's turn our attention to an asthma action plan and how to handle an asthma flare-up or asthma exacerbation, asthma attack. Asthma action plans are written pieces of paper that guide your thoughts and your actions for when your child, of how to take care of your child's asthma. Your doctor should help, you and your doctor should discuss this and be provided by your doctor. It's set up like a traffic light. Green, yellow, red. There's different types of breathing patterns for each traffic light color, and then different instructions for each of those zones or colors. Green zone, your child's well. Their breathing is normal. It's quiet. There's no symptoms. They're sleeping through the night without interruption from asthma symptoms, and they're fully participating in sports, physical activities, PE, without difficulty. You're not controlling their asthma by limiting their exercise. They would take their controller medicine as prescribed, and that use twice a day, and otherwise they're living life like any other child their age. Yellow zone is when the child is starting to have those mild changes in their breathing. They're still not so sick often that you might still think that they're fine to go to school. Their breathing isn't in distress, but you do hear cough. You might hear wheeze. They might complain that their chest hurts or their stomach hurts. You might notice their breathing's a little bit short of breath. It might wake them up at night. These are those mild symptoms that are letting you know they're not in good control, and that swelling and squeezing in the airway is returning. When you notice this, you need to use 4 puffs of their quick relief medicine, and you can repeat it every 4 hours if the symptoms return. If your child's been in the yellow zone for 2 days and they're not clearly improving, you need to call your provider. Call sooner if they're worsening, or if a dose of medicine doesn't keep them comfortable for 4 hours with their breathing. If you give 3 or 4 doses one day, 1 or 2 doses the next day, by the 3rd day, they're really doing fine. You've taken care of it, and you don't have to involve your provider. Just remember to discuss that with them, how often that's happening when you go for asthma checkups. Red zone. Let's back up. One other thing when your child's in the yellow zone is you do need to reduce your child's activity, because becoming very active when they're in the yellow zone is going to increase their symptoms. When a child's been in the hospital, they're discharged in the yellow zone, and we give these instructions to continue for the next 48 hours after discharge. Then we expect the child to move back into the green zone. Red zone, those are those severe symptoms, and we want you to recognize those quickly and be alert to them. Anytime you notice a child struggling to breathe, if you see them tugging, the skin pulling around the bones in their chest, either at their neck, if you can't really see that under their clothes, pull their shirt up so you can look and see if there's effort to their breathing, where they're using their muscles to push the air out of those obstructed air tubes. The ribs are showing in between. Their nostrils might flare. Usually the child's activity level changes. They're not as interested in being playful. You can tell they're not feeling as good with their breathing. Sometimes their speech pattern may change, where they don't have good airflow when they talk, so they'll talk in short, choppy breaths where they're having to stop and get their breath before, like I'm doing, before they can't speak freely, where their air just flows out for the whole sentence or several sentences in a row. Especially sometimes teenagers will sort of hide those symptoms and you don't notice it unless you really have them read something to you, sing something to you, where they're speaking more than just simple words, single words or short phrases. Have them talk enough that you can distinguish if they're in the red zone. So any one of these symptoms puts them in the red zone, just like any one of the previous symptoms puts you in the yellow zone. These are severe symptoms and they shouldn't be overlooked. When they occur, notice the time. Give 4 puffs of the quick relief inhaler, or if you have a nebulizer, you may use 1 vial of the quick relief nebulized solution. And if they're not better in 20 minutes, you repeat that dose so that now you're giving another 4 puffs or another vial of nebulized albuterol. So, for instance, if this started at 2 o'clock that I noticed my child, I'd give them 4 puffs. At 2:20, if the symptoms are still there, I would give another 4 puffs of their quick relief medicine. If they've improved, they move back to the yellow zone, but it's time to call the doctor and let them know that your child's been in the red zone. If they don't improve, it's time to give them the 3rd dose of medicine. So now it's 2:40, I've given another 4 puffs, and we're going to go to the emergency room, or if I'm concerned my child might pass out, we can't drive that far to the emergency room, I don't have transportation, it may be better to call 911 to come to you, but they need urgent medical care. You can take your portable quick relief with you as you travel, but that you don't want to have your child in the red zone more than 1 hour without them either improving by giving their medicine and then talking to your child's provider, or them not improving and you seek urgent care. This is serious when you see these red zone symptoms. When your child's discharged from the hospital, they get an action plan, but it's often in black and white. You can also see action plans like this one that's in color. On our website, the action plans are sample action plans, some that are fill in the blank, some that are pre-filled where the doctor would just fill in the specific doses they want to use. You can print those from the website and take it to your child's asthma provider to see if they will, to ask them to make an action plan for your child if you don't already have one. This may change over time. That's the benefit of having ongoing care. The blank is a written plan from the doctor to help you care for your child's asthma at home. School form, shot record, or asthma action plan. That's right. Now let's think about asthma triggers. They're listed on page 9 in the book. There's lots of things that trigger this inflammation and cause asthma flare-ups. The most common categories are anytime a child catches a respiratory illness like a common cold, allergies or irritants that are in the airway. The child's triggers can vary from person to person. Not everybody's triggers are the same, but recognizing and avoiding your child's triggers are a key to good asthma control. This is really the best non-medicine way to improve your child's asthma, is reducing their exposure to their triggers. So allergens. Some allergens are things that are inside the house, like dust mites, cockroaches, often pets, moles. Some things are outside the house that are more seasonal, environmental, things like tree pollen, grass pollen, weed pollen, moles that occur at different times of year. Often children with asthma also have allergies. They also may have eczema. All of those are sort of cousins of the same problem of inflammation that's triggered by allergies. If you're not sure what your child's allergic to, discuss that with your doctor, and they can be tested to see if allergies are a component of their asthma that often is a trigger. The more you control the allergies, the better control the asthma is. Irritants are things that you're not really chemically allergic to, but they do irritate the inflammation, the airways, and create that inflammation. The most common irritants are things like smoke, either from tobacco products, fireplaces, campfires, grills, extreme temperature changes like from hot to cold air, strong odors, things like chemicals, paints, perfumes, cleaning products, strong emotion, things like when your child cries really hard or laughs for a long time. You may notice that triggering asthma symptoms. Exercise is the one trigger that we don't want to avoid, but you may notice that your child, when they exercise, it triggers asthma symptoms. So let's talk about some of these individually. Respiratory infections, number one trigger for children, and it's often a viral infection, like the cold or the flu. So once you see those symptoms starting in the upper airway of a cold, runny nose, maybe low-grade fever, sneezing, coughing, sore throat. I shouldn't have said coughing yet, because coughing is your asthma symptom. But those upper airway symptoms, be on high alert for asthma symptoms to start. The more that you can teach your child just good hand washing, careful sanitation with not putting their hands and fingers in their eyes and in their nose to reduce how often they catch colds, will help. We recommend that a child with asthma get the flu shot every year to try to avoid getting the flu. A child with asthma that gets the flu, it may often make them sick enough to put them in the hospital, and at times really severely ill in the intensive care unit. So the trouble of a vaccine is well worth it to try to reduce the impact the flu will have on a child with asthma. The one medicine we don't recommend for kids with asthma is using cough suppressants, things like dextromethorphan. A lot of the cough medicines that are over the counter may have a cough suppressant in them. If your child's coughing, we want you to add their quick relief and then use that as the gauge for when to be in touch with their provider or to recognize when their asthma is worsening. So don't use cough syrups, cough medicines with children with asthma. Allergy medicines, mucolytics like Mucinex, decongestants, those discuss with your doctor, but those are not as they're not the same. We're talking about cough medicines. We don't want them, cough suppressants. We don't want you to use. Tobacco smoke is going to be an irritant that's going to make inflammation worse. The more you can reduce that exposure, the more it benefits your child. So we want you to keep cigarette smoke away from your children. Don't allow smoking in your house or your car. If you're the smoker, try to always go outside when you smoke. You can wear a smoking jacket that covers your clothes so that the smoke that collects on your clothes you don't bring back indoor. Wash your hands and your face when you come back inside after smoking. If you're at all interested in quitting smoking, if you're considering it, there's great help for you through the 1-800-QUIT-NOW number that's shown on the screen. They'll give you phone support, counseling to prepare to stop, and then give you encouragement and also the ongoing sort of accountability you need to stop smoking. It's also available on the website at alabamaquitnow.com. We know that smoking is something that's hard to stop. It's a very addictive habit, and we want you to know there's help if you're at all interested in stopping smoking. To seek help, would encourage you to do that. Exercise is the one trigger we don't want your child to avoid. We want them to be in the green zone where they can be fully active, fully participating in sports. If they're in the yellow zone, be in touch with your provider so that they don't stay there for long. Be sure that teachers, coaches knows your child has asthma in case symptoms develop at school or during sports. Have their quick relief available. Pre-treat them before activities if prescribed by your child's doctor. Sometimes warming up and cooling down exercises will help reduce how much exercise triggers asthma. Asthma blank irritate the airways and cause asthma flare-ups to start. Medicines, doctors, or triggers. That's right, asthma triggers. Now let's think about asthma at school. All students have the right to carry their quick relief at school, but they need written permission from their doctor. So in Alabama, there's a school medication provider parent authorization form that the physician has to fill out and sign, and then the parent additionally signs. That needs to go to school with their quick relief inhaler and their spacer. If children are struggling academically because of such severe asthma that they've missed a lot of school, there are things like 504 plans that can help make accommodations for your child's education. You need to talk to your provider or your child's school counselor about making those accommodations if your child's asthma is so severe that it's really limiting their ability to complete their academics. And then remember to let coaches and teachers know that your child has asthma so that they're aware of symptoms. If your child is sick one day in the yellow zone, well enough to go to school, send a note to let the teacher know, the school nurse know, hold them out of PE the days they're sick so that you're not sending the child not under good control to the school without giving the school a heads up. Typically, when a child's been hospitalized and they're taking the steroids by mouth, they hold them out of PE until the steroids are completed, is the typical instruction. Well-controlled asthma means your child's symptom-free most of the time, only needing quick relief every once in a while. No symptoms at night, not missing school, able to exercise and play, fewer flare-ups, few unscheduled emergency room visits, hospitalizations, doctor visits. Some family strategies to achieve good control are seeing your child's asthma doctor every 3 to 6 months for checkups. Let your doctor know how often you're hearing symptoms, how severe they are. Bring medicines and spacers to the visit. Let them know any flare-ups that required hospitalizations or emergency room care. And then really that faithful adherence to taking the controller medicine every day and refilling them every month. It's one of the most important keys to having your child under good control. Make sure that everyone who cares for your child knows how to give the asthma medicines correctly, knows how to recognize symptoms, identifying and avoiding triggers, and then knowing your action plan and following it, using it, knowing when to add medicines, when to be in touch with your provider, when to be in the emergency room. Your child's doctor should provide your action plan, discuss that with you, give you prescriptions. If they have persistent asthma, add a controller and adjust that. A lot of families have concerns about being on controllers, but it's actually safer and less side effect risk to be on a controller product for several years versus taking one 5-day burst of steroids by mouth. Fill out those school forms. The doctor should provide that for you for them to have quick relief available at all times. And then have those asthma checkups where they're seeing them even when your child's well, not just going to the doctor only when they're flared up. That is the end of this presentation. We hope that this has been a benefit from you. If you have other questions or comments, talk to your child's doctor about it, and so that you understand asthma and you feel equipped and ready to take care of your child's asthma. We want them to live a normal life and not let asthma really prevent them having a normal childhood. Thank you for your attention.